Welcome, everybody. My name is Benjamin Musher. I'm a GI medical oncologist, associate professor of medicine at Baylor College of Medicine in Houston, Texas. I'm also director of the GI Cancer program at the Dan L. Duncan Comprehensive Cancer Center in Houston that encompasses our University Hospital, Baylor St. Luke's Medical Center, the VA Medical Center, and our county hospital, Ben Taub Hospital. I see medical oncology patients with my colleagues. I conduct research, clinical trials and translational research, and also teach our many house staff training in medical oncology at our medical school and cancer center. It is my pleasure to welcome the attendees as well as our panel from Latin America, Middle East, and the United States. As part of our mission to promote medical knowledge through educational programs, the International Center at Baylor St. Luke's Medical Center in Houston, Texas, in collaboration with Baylor College of Medicine and the Dan L. Duncan Comprehensive Cancer Center, we are honored to host our 5th International Virtual Roundtable to our network of physicians, medical societies, and international medical community colleagues. Today's topic is a very timely one, an interesting one: management of GI and pancreatic cancer cancers during the time of the COVID-19 pandemic. During the next hour or so, we will hope to accomplish the following objectives. Number one, to provide an overview of how COVID has impacted globally and regionally, how the COVID pandemic globally and regionally has impacted the patient care in the Texas Medical Center, to review the challenges we are facing in evaluating and managing our patients during the COVID pandemic, and discuss biological considerations of COVID as they relate to oncological care and cancer biology during these very difficult and interesting times. The way that this program will work is the following. First, we'll have a lecture presentation by our guest speaker, our invited speaker, Dr. George Van Buren, who is a surgical oncologist at Baylor College of Medicine and the Dan L. Duncan Comprehensive Cancer Center. Throughout the presentation, you may submit questions. Please do so as they're coming up via the chat box located at the bottom right of your screen. And then what will happen is after the presentation, we'll have a virtual roundtable and hope to answer some of these questions to your satisfaction. If you have follow-up questions, that's fine too. Before introducing our speaker tonight, I first want to welcome our Latin American panelists who will join us after the presentation with their opinions and observations. One of these esteemed faculty is Dr. Frank Young from Peru. Dr. Young is an abdominal oncology surgery specialist. He received his surgery credentialing from Universidad Autónoma de Guadalajara. Dr. Young completed an international fellowship in the Department of Liver Surgery at Sloan Kettering in New York, and international fellowship in the Department of Gastrointestinal and Pancreatic Surgery at Mass General in Boston. Two very reputable institutions. He is the medical director of the Oncosalud AUNA Oncology Service and serves as secretary of the Scientific Action for the Peruvian Society of Cancerology. Welcome, Dr. Young. Dr. Harry Doran Arias from Ecuador is our other panelist. He's a professor of surgery at Universidad San Francisco de Quito. He has also served as Chief of Surgery Medical Director of the Hospital de los Valles. He completed his specialty training in general and digestive surgery at the University of New York, and later a subspecialty training in hepatobiliary pancreatic surgery and transplant surgery at the University of Virginia in Charlottesville. He is the founder of the transplant program of the Hospital de los Valles. He's a member of the American College of Surgeons, American Society for Oncologic Surgery, American Transplant Association, and American Association of Hepatobiliary Pancreatic Surgery. He currently has more than 30 international publications and his expertise in the management of surgical abdominal pathologies, including oncologic surgery and transplants. Welcome, Dr. Doran. Thank you, everybody, for joining. We will connect with you after the lecture to listen to your observations and also answer any questions and ask questions back. I'd now like to introduce our guest speaker, Dr. Van Buren. Dr. Van Buren is one of my close colleagues at Baylor College of Medicine. He's an associate professor of surgery, both at the Baylor College of Medicine and the Dan L. Duncan Comprehensive Cancer Center. He's also the medical director of the surgery clinic at the McNair campus, which is our main campus for our cancer center. Dr. Van Buren earned his undergraduate degree at the University of Texas at Austin and his medical degree at the University of Texas Medical School at Houston. He then completed his general surgery residency at University of Texas Medical School in Houston, during which time he spent 2 years at MD Anderson Cancer Center doing research in pancreatic cancer, colorectal cancer, and neuroendocrine tumors under the TE32 grant mechanism. He then did a surgical oncology fellowship at the University of Pittsburgh and did additional translational research in their special or dedicated translational research track. He is active in both patient care and research. He has spent over 15 years in training and practice, focusing on care for patients with pancreatic and gastrointestinal malignancies. He's been involved in basic research, clinical research, and translational research, and is a strong believer that only a solid, evidence-based research can lead to advances in the field of gastrointestinal malignancies. In addition to operating on many, many patients and taking care of many, many patients in the clinics and participating in tumor boards, he is an extremely active and passionate advocate of our therapeutic clinical trials and therefore an indispensable part of our research team. I've said a lot of credentials. I also want to say that Dr. Van Buren is a good friend and really an incredible, passionate and compassionate physician and a great person to work with. So with that, I introduce Dr. Van Buren. Thank you for speaking today.
Thank you, Dr. Musher, for the kind introduction today. I appreciate it. And thank you, Dr. Doran and Dr. Young, for joining us. I'm going to share my screen here and let's make sure that we can see the correct view of this here. Okay. There we go. There we go. Okay. So thank you very much, Dr. Musher, for the kind introduction, and thank you for everyone who has joined us today. I think this is a incredible time that we are all experiencing right now, and we are all learning as we go. Hopefully this discussion can provide some thought-provoking topics for discussion for our panelists. And for our members listening, provide some insight in ways to move forward. Disclosures. I've been on a scientific advisory board for Castle Biosciences. So our objectives today, as Dr. Musher had mentioned, first to provide an overview of the impact on COVID, both globally and regionally here in the Texas Medical Center. Review some of the challenges this has provided for our oncology patients, discuss some of the management strategies for adjusting our care in these patients, and then discuss some of the biological considerations that we've had to take specifically for surgery and oncology patients in this unique time period. So there's no question that the COVID pandemic has affected our life in every aspect. Interestingly, it has affected different countries and different regions in very different ways and on different time courses. Here within the United States, our regions have had different exposure time periods and different cohorts of people who have been affected. The New York experience has been very different from the Houston, Texas experience, and it's offered different challenges. there's been no question that healthcare has been exceptionally challenged during this time period. Oncologists and surgical oncologists are being forced to consider triage and rationing of cancer surgery cases for any number of reasons. The biggest fears initially are, number one, shortage of personal protective equipment for physicians to protect themselves. Number two, a shortage of personnel, our nurses, our physicians, our patient care assistants, all of our team members who help care for these patients. Next, something that we watch very closely here, our hospital capacity, our inpatient beds, and more specifically, ICU beds and ventilators to be able to care for all of the patients with COVID, as well as for those who do not have COVID. This is a major consideration for surgeons such as Dr. Dorn and Dr. Young, who do major abdominal surgeries. There's also desire to maximize social distancing among our patients and colleagues and staff. And there's a delay of at least 3 to 6 months that we have to assume will occur during this time period for our patients. I think it's really key that treatment decisions be made on a case-by-case basis. And I think the surgeons and oncologists' knowledge and understanding of the biology of each particular cancer is very important, as well as the potential alternative treatment options for the cancer. As well as every physician and surgeon must become exquisitely familiar with their own institutional and regional policies that are in place for care of these patients. So some of the principles that we have moving forward in this COVID era are, number one, maintaining a safe environment for surgical and oncology care, a real resource management. Next, we have to be able to be adeptly redirect the multidisciplinary care and mold our decision guidelines on how these patients are cared for. Something that we have seen in our environment has been a real harnessing of telemedicine to allow physical distancing, but still provide close care for our patients. Understanding some of the interactions between COVID and cancer therapy, some of the biological considerations outside of simple resource management, and then the ethical implications of triaging care or prioritization of care in this setting. And then lastly, advocating for our patients who are going to require oncology care in the midst of this COVID pandemic. So regionally, we here in the Texas Medical Center are a collection of numerous hospitals together that serve the whole Southeast Texas region. We have over 10 million patient encounters per year. We do over nearly 200,000 surgeries per year. In total, within the Texas Medical Center, we have nearly 10,000 patient beds. And in pre-COVID settings, we had about 1,500 ICU beds to provide care for all of those patients. This Texas Medical Center conglomeration, which has really during this COVID time come together and act as one area, has nearly 100,000 employees and is the 8th largest business district in the United States. It's the largest medical city in the world, excuse me. So this is a snapshot of the hospitalizations throughout the COVID pandemic here in the Texas Medical Center. And as everybody will recall, many of our colleagues down in South and Latin America experienced a spike very early on, very similar to New York. During that time period, Texas shut down. And you can see in April, we had a small blip early on, but we really locked down. And we had several months of a steady, low level of COVID population that we were caring for. Unfortunately, in the past couple of months, we have seen a steady increase in the COVID patients that we've been having to deal with. Now, the length of the time period that this has occurred has really been a challenging situation for us. This is a snapshot of the view of our total bed occupancy with both our floor beds and in the blue section, the ICU beds that we have that are available. Our bed capacity is something that very directly impacts our ability to provide elective surgery and more specifically, urgent or oncology care. We have to have those resources there to provide for our patients. In looking at this nationally, the Society for Surgical Oncology has laid out some simple guidelines and thoughts for us to work with in moving forward with the cancer care of our patients. Number one, we should operate on patients with aggressive gastrointestinal, hepatopancreatic biliary malignancies as indicated, including pancreatic cancer, gastric cancer, cholangiocarcinomas, and all of the diseases that many of us treat. The key to all of this is that the timing to therapy becomes critical. You've got to have the resources to care for your patients available. And this is when it becomes really important to look at this from a global multidisciplinary perspective. If systemic therapy is indicated in addition to surgery for your patient, consider neoadjuvant therapy to delay the time period when you may need to do a big major abdominal surgery. If that patient is tolerating that neoadjuvant therapy, can we consider continuing therapy for a longer period of time or potentially delaying the surgery? There are certain cancers that we do treat, asymptomatic pancreatic neuroendocrine tumors, duodenal or ampullary adenomas, gastrointestinal stromal tumors, high-risk IPMNs of the pancreas. These are diseases that we all know carry a significant risk burden for them. However, if we can delay a patient through a 1 month stressful time period or 2 month stressful time period when the hospitals may be at greatest capacity, maybe we can do our operation on the other side of the spike or the curve. The other thing we can consider is neoadjuvant therapy, ablation or stereotactic or radiosurgery instead of aggressive resections for other liver malignancies when possible. Let's quickly look at neoadjuvant therapy in pancreatic adenocarcinoma. So we all know, as surgical oncologists and oncologists, there are numerous advantages to neoadjuvant therapy. The ones we've all listed over the years, first of all the patients get their intended therapy. Unlike the adjuvant therapy trials where 30% of the people never got their therapy because they were too sick, they're too beat up, everybody's going to get their therapy. There's conceptually the idea that you could increase your R0 resection rate. There's the concept of there's intact blood supply. We may be doing a better job of getting that therapy to the patient's cancers. The reality is also these are systemic diseases, and we offer immediate treatment to these undetected surgical systemic diseases. Many patients also consider this basically a biologic stress test for the patients. Allow those patients that have an aggressive disease to allow it to reveal itself prior to putting them through a big surgery. The question gets to be within the COVID environment, do we allow these patients to get their systemic therapy for a set period of time or even a longer than normal period of time to provide them cancer therapy without putting them through the stress of the surgery that might require major resources? Most people will follow the national guidelines set by Society for Surgical Oncology and the American Hepatobiliary Surgery Society, where we use the definition of borderline resectable tumors, tumors that have some vein distortion or involvement, short segment hepatic artery involvement, or any abutment of the superior mesenteric artery. These are, of course, anatomic considerations that we use to describe our patients. Conceptually, we all know when we see these patients, there's also patients who are oncologically or biologically borderline resectable, those who have elevated CA19-9s. They have something on their CAT scan that is concerning to us, that they have a more aggressive disease than simply that which is seen in the primary tumor. In addition, we all know there are those physiologically borderline resectable patients. Those patients who may be a little bit more elderly, have a few more comorbidities, who may not tolerate or have that reserve to tolerate a big surgery as well. The national guidelines that we generally base this off of are those that are borderline resectable or locally advanced should receive the neoadjuvant chemotherapy. Within our group, historically, we have recommended neoadjuvant therapy to all those who are borderline resectable and locally advanced. I think in the past several years, many of us have moved towards treating even the resectable patients with pancreatic cancer with neoadjuvant therapy. In the pre-COVID era, we would oftentimes make a clinical decision on the timing of that therapy. Maybe we would give them 3 months or 4 months of their total 6 months of therapy upfront, do the surgery, and then give some therapy on the back end. This was often a clinical decision of how that tumor was responding, peeling away from the vein, the response we were getting, how the patient was tolerating the chemotherapy. In this COVID setting, this plays a much larger role. Can we extend that period of time that we give their patients their neoadjuvant therapy, potentially riding through a wave or a spike of hospitalizations to get them through that care? Similarly, in neoadjuvant therapy for gastric cancer, after the MAGIC trial, we all saw the benefit of preoperative chemotherapy for T2 or greater gastric adenocarcinomas. And again, many of us follow our national standardized guidelines for those are T2 or greater gastric cancers or with any nodal disease. We put them squarely in the setting of their preoperative chemotherapy. However, that generally has been sandwiched with the approach of doing their neoadjuvant therapy, surgery with some adjuvant therapy. The question gets to be is, should we still provide with our staging procedures? I think we'll discuss most of our staging laparoscopies and staging procedures are still safe in the COVID era. Can we extend the preoperative therapy for a period of time to avoid having to put the patient through a large abdominal total gastrectomy or subtotal gastrectomy during this time period? In general, the recommendations that the Society for Surgical Oncology ended up coming up with was that if these patients have cancers that cannot wait 2 to 3 months and have a significant chance of benefiting from the surgery, proceed with the surgery. For patients that require a palliative operation, they've got a nearly obstructing tumor, they need a gastrointestinal bypass, or they have a tumor that is causing some obstruction relief, proceed with those palliative procedures to provide those patients relief. Elective operations should be foregone during this time period, things that are not directly oncology related. And surgeries that you're not going to have the readily available or appropriate non-surgical options there, we should consider it. We shouldn't do surgeries that can be safely delayed. The gastrointestinal stromal tumors that are, not asymptomatic, the asymptomatic pancreatic neuroendocrine tumors. These tumors, we really should delay their care until a time when we don't have a major surge that is straining our hospital's resources. And then obviously true emergencies, we need to proceed with care. Some of the other things that we have really learned on our feet as we moved along, telemedicine. This is something that we in our group did hit or miss prior to the COVID pandemic. If you take a look at this graph, you can see early in March, these are kind of the clinic volumes. You can see those plummet through mid-March, and you begin to see a rise in first just phone call visits, but then increasing our telemedicine visits. And this has really been a boon where there's been a percentage of our patients who we're able to provide telemedicine care for. This is kind of a snapshot of our different specialties. And as you can see, some specialties, things like psychiatry, urology, Department of Medicine, they've been able to provide a higher percentage of their care by video conference or teleconference. Some of our other disease sites, such as surgery, we've definitely been able to do that, move some postoperative visits, even some preoperative visits to it. However, it has still required some in-person visits. As you can see there, in the oncology world, infusion and diagnostic services still require in-person visits. So we haven't really been able to capitalize it there. But I think telemedicine has really revolutionized our care, allowed us to reach out to some patients who may have been isolated or unable to receive care, and has allowed us to expand our umbrella. Some of the other biologic considerations I just want to briefly touch upon that we need to consider as well. Dr. Dorn and Dr. Young probably also likely treat a lot of these patients by minimally invasive methods, whether it's a diagnostic laparoscopy, a laparoscopic distal pancreatectomy, a robotic Whipple, whatever the operation that you're doing is. Minimally invasive surgery has presented somewhat of a challenge in the COVID area. There has been a principle that we don't want to overly expose all of our healthcare professionals, our anesthesiologists, our surgeons. There has arisen the concept that there's an increasing risk of pathogens within the peritoneal cavity. There's concern that COVID can be disseminated during insufflation of the abdomen with leaks of air or on exsufflation with contamination of the personnel as well as airborne particles. Some of the mitigation strategies that many of our hospitals have implemented, preoperatively testing the patients with the RT-PCR at least 3 days prior to the surgery and having them isolate prior to arrival at the hospital. Air seal devices to continuously evacuate the intra-abdominal air to prevent circulation or leakage of that air within the room. All cases done with N95 and other covering masks to prevent airborne inhalation of this. One of the other major things that we've noticed at our hospital, and as was published in JAMA recently, the coagulopathy in these COVID patients has been unbelievably marked. There is significant microvascular and macrovascular thrombosis that has occurred. Many of our oncology patients, unfortunately, are going to get exposed to COVID and potentially contract COVID. The patients at our hospital that are getting diagnosed with COVID are getting fully heparinized and getting full anticoagulation therapy to prevent many of these complications, which lead to disastrous problems on down the road. Our cancer patients are already at very high risk for thrombosis, and this is a consideration we really have to pay attention to in the care of our oncology patients. So in conclusion of my snapshot presentation here, there's no question that COVID-19 has changed our lives forever. Things are going to be different from here on out. Each region and location must come up with a plan that suits them. They've got to appropriately utilize their resources as well as adhere to the standards of patient care. Multidisciplinary care allows us to provide flexibility in care for these patients and is critically important for us to be aware of all of the tools we have to care for our patients. Timing of therapy is going to be critical in care for these patients. Telemedicine, I think, has enhanced our ability to care for our patients and is going to be something that we're going to continually need to do to help promote social distancing. An important something that we have seen here in Houston, Texas, as we rode through a first small spike, spent several months with dealing with this, and they're now seeing a second spike. Short-term plans do need to be altered for a period of time. We've got to have some long-term plan to care for these patients, and that there are going to be repeated waves of this disease that we're all going to have to deal with. And we've got to come up with a game plan to appropriately care for our patients. One thing that I think we have all mentioned as groups and has been considered is we really should consider logging these patients onto a COVID cancer registry. There's going to be immeasurable things that occur to our patients. We've got to be able to record these things now to, number one, care for the patients in the future who will be exposed to this, and to track and see what's occurring with our patients to make changes as necessary. So I thank you, everybody, for the time and listening to us as we spoke. I've got my contact here, and I will now turn this back over to Dr. Musher, our moderator, and Dr. Dorn and Dr. Young, our esteemed panelists. Unmute.
Sorry about that. Dr. Van Buren, thank you. Excellent talk. So many complexities of the situation. I know that we're all facing these in our daily practice. While I ask a couple of questions for the panelists, please submit any questions that you all have, any experiences you've had or questions you have specifically. So first, let's start with Dr. Young. Dr. Young, tell us about how this has affected your practice in Peru, not just surgeries you've done or haven't done, but how you've interacted with your colleagues, how you have structured your clinics, how you've structured your OR schedules, etc.
Okay, thanks. First, thank you all for the invitation, and I'm going to talk about AUNA. As you know, AUNA is a private health company who has a network of private clinics throughout the country. And OncoSalud belongs to this group. OncoSalud is, I think, the only oncology company in Peru, and is specialized in prevention, diagnosis, and treatment. And we have around 1 million affiliates to our program, and with an annual average of more or less 2,500 new cases of cancer per year, and we treat all of them in our clinic. What we have been seeing on the last 10 years is that we have around 300 new cases per month, with the main diagnosis being breast cancer, prostate cancer, lung, and gastrointestinal cancers. A little different of what is going on with the country. And in gastrointestinal, what we see as the primary diagnosis is colorectal cancer and gastric cancer. We have not too much pancreatic cancer and also hepatobiliary cancers. As you probably know, the first case of COVID in Peru was diagnosed in Lima. The second one was in our clinic. And the entire country was declared on a mandatory quarantine less than a week before that. This quarantine has finished in Lima, not in all the country, a week ago, and the official figures show around 310,000 infected and almost 11,000 people who has died from COVID, although probably the death toll now exceeds 30,000 people. What we did in OncoSalud was immediately, and following international recommendations and what we saw in China and Europe and in New York, we suspend all oncologic treatments and medical and surgical. And the first 15 days of our quarantine and lockdown, we started analyzing all our active cases with all the medical staff to establish them according to priorities. In the case of surgical patients, all cases were deferred, and we start just doing emergency cases and cases considered to be urgent. What else can I tell you? In the gastrointestinal area, all cancers of the rectum below the peritoneal reflection were referred to TNT, as is our general practice. Colon cancers with risk of obstruction and bleeding, and those T3 and positive without comorbidities were also operated. And in cases of resectable or borderline pancreatic cancer, were all referred to neoadjuvant treatment. Similarly, we did with cancer of the distal esophagus.
Did you change your time course for your neoadjuvant therapy for either your gastric cancer or pancreatic cancer? Did you give additional neoadjuvant therapy for some of those patients?
Right now, we are with the pancreatic cancers. We are just talking about this with the oncologists, because most of our patients are just finishing the first 3 courses. So, as you know, we are still having a lot of cases. In my clinic, I still have ICU beds for the surgical patients, but we are in a complicated situation. So we are thinking to extend this chemotherapy for these patients. Mm-hmm.
Yeah, I'll chime in for the gastric cancer situations. You know, what's interesting with the MAGIC trial, as you all know, is that the vast majority of people got those first 3 cycles, but it was really 9 weeks, so 2 months of chemotherapy, and a much smaller percentage were able to get the adjuvant component of it. My philosophy has always been that if someone's responding well to neoadjuvant chemotherapy and they're tolerating it well, there's little to no downside of giving more chemotherapy beforehand, because you almost have to assume that more than half of those people, based on the MAGIC trial at least, are not going to get their adjuvant therapy. So it makes sense. I think the tougher ones are people who are not tolerating it well, people who are not responding, although you can also make the argument that biologically they may not benefit from aggressive surgery so much because their microscopic disease is not getting dealt with appropriately. So those are the ones I think a little bit tougher, but if they're responding, at least from my perspective, it's sort of a no-brainer. Why not just keep going, take more of a TNT approach? I wanted to talk about the humanistic aspect of this. We, at least in the oncology world, a lot of these things we do don't cure people. They're palliative. Not only the medical oncology side, but also sometimes on the surgical oncology side. And if we're in the quote business of trying to extend people's lives with quality, what kind of quality do people really have if they're cooped up in their houses? They can't see their kids and grandkids, et cetera. So I want to know if y'all have had any experiences with people who have expressed any of these things to you, how depressing or upsetting this can be, dealing with cancer and also not being able to do things they enjoy doing.
Well, for example, one of the things we decide to do at the clinic is that all patients who were going to be hospitalized go into the clinic without any familiars. No, they are always alone at the clinic, and this is very, very, very tough for the patient, for the family, and also for the people who works at the clinic, because we were used to be an open clinic with no rigid visit times, and we have a lot of activities for the patients, and now we have a quiet clinic with no people walking around, patients in the rooms alone. So it's very tough for patients, for family, and also for the personnel who works there.
Dr. Doran, do you have any thoughts for us on this or anything else you want to comment on?
Well, yeah, I mean, we're in such a unique time in humanity that we're going to talk in medicine and the pre-COVID area and the post-COVID area is going to be a huge change. We're in the middle, unfortunately. So there's two things that are impressed me a lot. One's, as Dr. Young said, the oncology patients are vulnerable patients. They are going through a emotional roller coaster, and family, it's great support. And not being able to share, with their loved ones during this time, especially patients who are in palliative care, I think has had a huge impact, and we'll see that in the next couple of months. And the other thing is the medicine. We're pushing the limits here, and so it's going to be. There's going to be a lot of data in the next year or so from the surgical and medical oncology point of view that it's going to be amazing. It may change a lot of how we're treating patients right now, because we've been 2 to 3 months changing our guidelines because of COVID. Before that, if you tell any of our colleagues, you have to stop doing treatment for 2 to 3 months, nobody will do it. Now we'll be forced to. So we'll see what happens in the next year or so with the data. It's going to be interesting.
Yeah, it's interesting. Especially early on, most of my patients were much more concerned about how COVID was going to affect their cancer care. They weren't like, listen, I got pancreatic cancer. I don't have COVID, right? I'm much more concerned that I'm not going to be able to get taken care of, whether it's chemotherapy or my procedures, my ERCPs, whatever it is. And things might have changed a little bit in Houston as the pandemic's really gotten to be rampant, but that was the bigger concern for a lot of these people. Dr. Doran, I understand you have some slides to share with us. Would you like to do your quick presentation before we open it up to the audience?
Sure. Well, I prepared just, a small amount of slides with a little bit of what's going on in Ecuador. And also, I have some of the same concepts that Dr. Van Buren shared to us. So I'm going to go pretty quick through those. Ecuador, it's around 60 million, the population of our country. And our first case was confirmed on February 29th. That was in Guayaquil, which is the biggest city of Ecuador. And almost 11, 12 days after that, the government declared the national health system as an emergency. And a couple days after, March 13, was the first case confirmed in Quito, the capital where I live. And 3 days after, the government prohibited all the public events and the borders were closed. At that time, we have 28 cases and 2 deaths, and such a small country that was quite impressive. And March 17, the authorities declared a quarantine. So we've been in lockdown for almost 60 to 90 days, depending on where do you live. As per now, we have around 64,000 confirmed cases. And that's pretty much an underestimation after all the, there's not a lot of testing going on. And almost half of those patients are at home in stable conditions. And we have almost 5,000 deaths. Our health system, the national health system, this is not the private sector, it's the public sector, has 28 COVID specific treatment hospitals with small clinics, like around 2,100 small clinics around the country. And it's been challenging because as Dr. Van Buren and Dr. Young said, we have to stop almost every treatment, especially in the first 15 days that we didn't know exactly what was going on, where were we heading to. So everything was in a pause. Our life was paused like a film. So it was pretty strange. And we've been learning from the different countries like China, what happened in Spain, Italy, what happened in New York. So we start to adopt those experiences in our country, and I think things got under control rapidly. Even though it's been tough times, I think everything right now is a little bit more stable. We started with a multidisciplinary approach with our surgical oncology, with our medical oncology colleagues, and we adapt the guidance of the Surgical Oncology Society, and pretty much we try to defer all elective cases, especially for colorectal cancer, early stages disease, and we just operate on emergencies, perforated patients who are bleeding, obstructions, and we lay everything for especially patients who were reacting nicely to neoadjuvant. So those patients were just being followed up. Regarding neuroendocrine tumors, just symptomatic patients were treated, and as well as colorectal obstructions, bleeding, or pain were treated, as an emergency in surgery. Otherwise, we just wait, and especially what was concerning were some patients with NETs who cannot be controlled medically. Those patients require surgery, and also lesions with significant growth or very short doubling times. Gastric and esophageal, Dr. Van Buren, I think, went through this, and it was very clear. So basically, we deferred every surgery for biologically less aggressive cancers, like Dr. Van Buren mentioned, GIST tumors, unless they were symptomatic and bleeding. Otherwise, we just wait and let patients finish their neoadjuvant chemotherapy regimen. And if they were tolerating the regimen, we just keep them for a couple more cycles, and they've been doing pretty good. where I had some trouble was with hepatobiliary and pancreatic tumors. I have some cases where the patients presented with a lot of complications due to the growth of the tumor, a lot of obstructions, a lot of have some pancreatitis cases. Pretty much every patient with the pancreatic adenocarcinoma was treated surgically, except patients who were borderline, which neoadjuvant therapy has been a standard of care. And I have some patients who went through neoadjuvant therapy, and they've been doing pretty well in the follow-up. I didn't have any patients with peritoneal surface malignancies, but the recommendations from the Surgical Society is to just operate on a patient with malignant bowel obstruction, or if a palliative procedure is feasible. Otherwise, we also wait and see and consider neoadjuvant systemic chemotherapy for high-grade appendiceal cancers, gastric cancers, colorectal, mesothelioma, they're high-grade, and desmoplastic small round cell tumors. So I think it's been challenging for everybody. The good thing is for the medical personnel from countries where the pandemic was not impacted right away or initially, we have some time to prepare, and we have some time to also have data from other countries to develop, adapt them to our reality, and I think that's been really helpful. I want to finish with this slide. This is a personal thing. This is my granddaughter. She's going to be a 1-year-old tomorrow. So I want to wish her a happy birthday, and I wanted to finish with that. So I'm ready for questions and talk to you guys a little bit more.
Sorry, thank you so much, Dr. Horn. I'll give the medical oncology perspective a little bit. We're a little bit different because our treatments are outpatient, 95%, at least from the GI medical oncology world. 98% of the chemotherapy I give is outpatient. Our building is its own big outpatient center, so we don't have a lot of COVID patients, certainly no sickies in our building. The screening at the front has been, I think, appropriately aggressive. So my practice, I think, of hundreds of patients I see, I might have had 1 or 2 that I know were COVID positive, and I actually had nobody on chemotherapy who became COVID positive, at least symptomatically COVID positive during their treatment. The other thing to remember is people talk about chemotherapy and immune suppression, but really the chemo we give is not very immunosuppressive at all. We're talking about people who have cancers that are not immunosuppressive in themselves, and their therapies, they might drop your white count for a few days and that's it. So I think our leukemia, lymphoma, BMT colleagues are really the ones who have had a much harder time with this. For us, it's been pretty much business as usual. We've been treating people with chemotherapy, targeted therapy, immune therapy as well, although there are some data showing that there might be some complications with immune therapies and pneumonitis with COVID and other types of autoimmune problems with it. But from our perspective, it's been pretty much business as usual. Clinical trials have been tricky, and I wanted to ask the three of you, when you think of academic centers or centers of expertise, right? There are really 3 things that set them apart. One is individual subspecialization, which we talked about. 2 is, I think, the multidisciplinary aspect of it, people getting together in tumor boards and really picking apart cases and coming up with plans. And 3 is obviously clinical research, in addition to training junior people. So give us some thoughts about what y'all have done in your institutions for your tumor boards and your training and your clinical trials. I guess we'll maybe try to pick it apart a little bit. Dr. Young, why don't you talk a little about how your multidisciplinary clinics and tumor boards have worked during this time?
Well, actually, we at the institution have very few tumor boards dedicated for. We have a GI tumor board and we have a breast tumor board. But with the situation we are living in Peru and on Cosalú, we start our big program of specialized tumor boards. So now on we have tumor boards dedicated to GI, breast. We have also for gynecology tumor boards, and also for lymphoma and leukemia. And they have been very active during this last month, using all this technology that we are some people discovering and using. They are being much more active using Zoom than going into a meeting. So I think for us, we have improved a lot because of COVID and the situation with tumor boards, with telemedicine. We have done around 3,000 teleconsultas, as we call it, for our patients. And one of the problems that we have also seen is that we have stopped some of our medical residency programs because we were very concerned of exposing these guys to surgeries, and also clinical trials have stopped for a couple of months. We are now re-engaging with them, no?
Dr. Van Buren, you're very involved in the education component of the Department of Surgery at Baylor. Tell us what's happened with education of surgical residents and fellows.
So that's been a challenging process. I mean, our residents, just like all of our healthcare workers, are at risk. And I think, as you guys with your trainees, they may be even more so at risk because they are the ones who are oftentimes in-house at night on the front lines there. So, we've very actively shifted our residents to a shift work schedule. Basically, instead of our standard services where you have a chief resident and a third year and a first year all on your service, where we have a bit more skeleton crews that are present there, and really conserving that manpower that's been present there. We have shifted all of our morbidity and mortality conferences to Zoom conferences. Just like Ben, we've obviously shifted our tumor boards to the virtual tumor boards as well, to be able to communicate as well. And then, interestingly, from the research standpoint, we are finalizing in the next few days where the IRB is going to be approved for us to do telemedicine consents for all of our patients. So you can enroll the patients. And this is actually an incredible boon for, instead of you having to have your research personnel always in clinic or bouncing between one clinic and the other, once we establish a telemedicine ability for them to consult the patient, they can get that consent at some other time when the patients, may have to run off after clinic, that type of thing. And so from a research standpoint, that's also been, I think, we paused a lot of enrollment for some of our actively enrolling trials, but that's something moving forward that I think we're all going to have to learn to adjust to this moving forward. I mean, I think the social distancing is going to be here for an extended period of time. And so these are all adjustments that are going to be necessary, and I think are probably going to continue for a period.
Good points. Yeah, for our clinical trials, we have several open, many open for GI, but 3 open for pancreas, and thankfully, they let us continue to enroll in these carefully on a case by case basis. You can consider some things to be essential and not. What's essential and what's not, right? If you're a pancreatic cancer patient and you got stage 4 disease, everything's essential. There isn't anything that's not essential. So I think we were able to make the case that we could put people on clinical trials as long as they were done carefully and properly. And I'm glad to hear about the consent. I didn't realize that, but thank you for informing me. We're at the same institution about the IRB, because they've regarded these clinical trial coordinators as non-essential staff, but I consider them to be essential. I can't do my job without our clinical trial coordinators. So I think we have to roll with the times, right? We have to make compromises and figure out how it's going to be. But I asked the education question because we don't, like you said, we don't know when this is going to end. And you can envision a situation in which surgical trainees or medical trainees might lose a substantial percentage of their training time, whether it's doing cases or seeing patients or whatever it is, because of this pandemic that it's not going to end anytime soon. Dr. Doran, any thoughts from you from the research or multidisciplinary perspective? What's gone at your institution?
Well, I think that the learning, the residency programs, all the educational programs of the hospitals in general in Ecuador have been they stopped, and we just reduced as much as we can the number of staff at the hospital. That includes medical students and residents. In our institutions, our medical students were out for a month, especially a month and a half. We do have residents and also surgeons who just graduate and stay in-house at nights, sometimes to take care of the patients. And so all that has been challenging, because we didn't know exactly what was going to happen. So for a month or so, we stopped everything. And virtual medicine has become a great success. We've been able to have a lot of different conferences with the med students and the residents. And I think a lot of research is going to come out of this. And also about telemedicine, patients love it. Believe it or not, they really love it. They like it. They feel protected, especially on these times. And also, you're able to keep in touch with them. Just hearing your physician, the guy who you have confidence on, it's good for them. So it's been an eye-opening to me, and I think there's a lot of road to go through.
Thank you. So we're pretty close to wrapping it up. Any final comments from anybody regarding any subjects that we didn't touch on? Looks like we don't have any additional questions from the audience. So I'll just ask Dr. Van Buren, Dr. Young, Dr. Doran, any closing comments of anything we haven't touched on?
One of the biggest concerns we are having here in Oncosalud is that we used to have around 350 surgeries per month, and of those surgeries, around 70% were major surgeries. We have seen a very dramatically drop of the numbers of surgeries, and of course this is because we have stopped doing a lot of surgeries. But we have been reviewing our data, and for today, we have already completed all the cases we were unable to perform on March. And right now, I was looking my numbers, and I was seeing that comparing our practice with the last 2 years, we have around 1,000 cases we haven't received to our clinic. It means that we really don't know where are those patients. They are at their houses. They don't have the ability to go to any private clinic or private hospitals or public hospital, because every one of those are collapses in Peru. So we are expecting, we don't know when, but we are going to have a lot of cases coming probably with very complicated situations, and I think we are not prepared. I don't know if Ecuador is going to have the same problem, and I don't know about United States. What are your thoughts about that?
It's very concerning and very complicated. I work at the county. I also work at the county hospital, and we're concerned about that as well. Dr. Doran, Dr. Van Buren, any concluding comments from y'all?
Well, I agree with Dr. Young, and that's been something that's going on into my mind for a couple of weeks. I think we're in a great area right now, and we don't know if we're going to receive a lot of patients with those patients who are at home because they don't want to get exposed, or if we're not going to get the patients because the stage of their disease is going to be too advanced. So that's the gray area that I think we're standing right now. And unfortunately, the only thing that's gonna answer that question is gonna be time. And I think that's our problem right now.
Dr. Van Buren?
I think the biggest thing I've taken away from this whole experience is we have to be light on our feet and adaptable. It's amazing how all of our countries have rapidly, embraced telemedicine. Within probably a couple of weeks, you ramped up your clinic with it. And same thing with changing hospital resources. We clamped things down for a period of time, thought we had a good handle on it, and we're getting an upswing again. And we're learning how to make adjustments and make moves on the fly. And I think we have to be much more aware of our resources that we have and allocating those appropriately moving forward. But just being light on our feet is, I think, what we're going to have to be for a period of time.
Thank you, Dr. Van Buren. So we'll wrap it up. Thank you, Drs. Young and Dorn, for your participation. Thank you, Dr. Van Buren, for your lecture. I'm asked to recognize and acknowledge the following entities who have supported today's program: Society of Gastroenterology of Peru, the Peruvian Society of Cancerology, Peruvian Society of Oncologic Surgery, Oncosalud, AUNA, I know how to pronounce that now, Hospital San Javier Medical Education, Guadalajara, the NCI, or National Cancer Institute, INCAN in Mexico City, Universidad de San Francisco de Quito in Ecuador, Neuro Quito in Ecuador, Hospital de los Valles in Quito, Ligas contra el Cáncer in San Pedro Sula in Honduras. Finally, we'd like to invite you to connect to our 6th virtual roundtable on Thursday, July 23rd at 5 p.m. Central Daylight Time, which is Houston time. The debate will be between 2 breast cancer giants, Drs. Ellis and Alistair Thompson. The topic will be neoadjuvant endocrine therapy, whether it should be standard for all women with ER-positive breast cancer. To receive updates and reminders, please subscribe to the St. Luke's YouTube channel. Thank you, everybody, and good night. Be safe.